Welcome to Grassroots Ohio, conversations with everyday people working on important issues here in Columbus and all around Ohio. I'm Carolyn Harding, and today I'm talking with three medical workers on the front lines of the COVID-19 crisis here in Ohio. We've all been impacted by this deadly pandemic virus, yet these folks are on the front lines, tending, treating, nursing, comforting our most vulnerable in their deepest need. They are facing life and death head on daily. They are our heroes. One of our guests is a traveling nurse. One is an ER tech, one an urgent care medical doctor. Two of our guests are choosing to remain anonymous. Traveling nurse is a registered nurse based in Central Ohio. She has worked as a travel nurse in a variety of specialties in the hospital setting for the past 5 years. In January 2020, she started an 8-week contract. Then COVID hit, and she's been extending and extending and extending to this day. She's been assigned to 3 different facilities over the course of the COVID pandemic and has most recently been assigned to a COVID ICU unit in a facility that is undersurged due to the COVID crisis. ER Tech is an emergency department technician in a small, independent, not-for-profit hospital in Southeast Ohio with less than 300 beds. As a tech, she takes vitals, assists nurse by drawing blood, running errands to lab cleaning, stocking, performing EKGs, transporting, and doing compressions on patients. Brad Cotton is an MD, an ER physician for 40 years. He started off as a paramedic in Cleveland, studied nursing at Kent State, and then medical school at Ohio State. He's active in Ohio SPAN, Single Payer Action Network. Welcome to Grassroots Ohio. All
Thank you.
3 of you. Well, from today's Democracy Now! Headline, the United States has once again shattered records for daily coronavirus cases and deaths, with nearly 250,000 infections reported on Wednesday alone. More than 3,600 Americans died of COVID-19 on Wednesday. By far the worst one-day death toll for any nation since the start of the pandemic. And here in Ohio, in total, we have lost 7,777 people to COVID-19. And we are in the middle of this same surge. Can you tell us what environment you're working in now and what you do on a daily basis? Let's start with you, travel nurse.
Thank you so much for having me. It's been interesting to see the progression of the virus over the course of the pandemic. On the ICU unit where I am, patients are critically ill. Many of them have, all of them have compromised respiratory. They're not able to maintain their oxygen saturation and breathing at a level that is sustainable without supplemental oxygen. We're really trying to balance the patient's symptoms and the underlying contributors, mostly related to respiratory, heart, and kidney functioning, all which are impacted as adverse reactions to coronavirus. So we spend a lot of time either weaning patients down from higher levels of oxygen, supplemental oxygen, or, in more unfortunate scenarios, increasing their oxygen or advancing them to higher levels of supplemental oxygen. Monitoring telemetry for any heart rhythm changes, monitoring their fluid volume, running multiple labs, and keeping up with their medications and all of the doctor's orders, and trying to collaborate care with the other professionals on the health team.
Excellent. How about you, Dr. Cotton, Brad?
Well, first of all, I'm happy to be on here with ER tech and travel nurse. In fact, I was listening to see if I might recognize a travel nurse because I know a number that have gone into that kind of work. And I'm proud to have started out as an ER tech and a medic on the streets, gone to nursing school and on to med school. In my personal situation at work right now, I'm doing urgent care work only, which means that I'm seeing people that have uh, coronavirus that we're testing for, but I actually see them in a relatively safe environment, about as safe as can be. I actually see them outdoors in the parking lot, and I'm sending them for testing. And then we follow up with the testing results. I mean, to some extent, I must say I feel sort of survivor guilt, you might call it. I've served many decades in the emergency department. But my professional association, the American College of Emergency Physicians, sent out an email communication in March and again in September, warning that we ought to get some of our more at-risk docs off the front line. That would include me. I'm 66 years old, have a pacemaker, although I keep working just fine with that, but also I'm very well controlled diabetes and hypertension, which my professional association is telling me to get off the front line. I'm fortunate that I was able to do so. But certainly my heart, my soul hurts every day at my brothers and sisters that I was advised to report to the rear that are still there on the front lines of this, and seeing, we get idiotic flyovers and people buying us pizza back in March and April telling us what a great job we're doing. But nobody seems to be willing to actually look at facts, to look at truth about what it takes to protect nurses and healthcare workers. That is, wear a mask, don't visit people at Thanksgiving. We are being thrown into the fire with, superficial praises while nobody's willing to do what it takes to protect us. I just noticed right before signing on here a headline that the feds are cutting back on shipment of the Pfizer vaccine, and Pfizer says they have millions of doses sitting in their warehouse. Our government, our current administration has failed so badly. The proof is we have less than 4% of the world's population, but greater than 20% of the coronavirus deaths. And if this administration was fighting World War II, we would have lost. It's not up to the states. We need a coordinated campaign to get the vaccines out, and now we can't even do that. And our healthcare workers are being thrown into the furnace.
All right, thank you. And Brad, we'll get your perspective from all these different areas. I appreciate coming from the side, not really the sidelines, but from the perspective where you're dealing with people that are just finding out or coming to see if they've got a coronavirus. Let's go on down to ER Tech. Can you tell us what the environment is like where you are working?
Sure. We are seeing ebbs and flows. There's some days when we have COVID patients, we have a dedicated area for them, but sometimes that overflows and we have to clean out other rooms, remove the supplies and put them, in other places. But we're seeing ebbs and flows, which is nice to give the nurses a break. The COVID unit itself it's rough. It's grim. You're in and out because, they have nothing done. So they have to have blood work, EKGs, urine samples, you name it, plus all the medications and breathing treatments and x-rays and CTs. So it's a lot of work. And sometimes there's not the staffing over there just because of the ebb and flow and, metrics of an emergency department. And that makes it extra hard, especially when it's full and you've got critical patients. But we see it, we get a lot of surprises these days. We're getting, people, because the symptoms mimic, other conditions, we might, think we have someone with chronic COPD exacerbation or congestive heart failure. And guess what? We find out, oops, they have COVID. And we weren't isolating. We all wear masks, but, we don't necessarily isolate every single person in the ER because it's impossible. We might get someone in with an accident and oops, find out later they had COVID. We get a lot of surprises and not fun surprises. And then we get a lot of people walking in that are worried about their symptoms, and they may not be as severe yet, but I've seen us send people home, with home O2, and they come back in and they're crashing. So the same day. So that's kind of what we're seeing.
Let's go on with the crashing. What are you finding, travel nurse, during this surge? Are you at capacity? Is there still room in your unit? And what does it mean by crashing?
So we've opened up 3 additional units to receive COVID patients. We are at max capacity. We have no space. We oftentimes are doing everything we can to wean patients off of higher levels of supplemental oxygen and critical care that they have to be on the ICU unit for in order to make room for people who are on a medical unit or on a non-ICU unit that really need an ICU bed. And every day we're gridlocked. I mean, there's nowhere to go. What it means to crash is the point at which a patient either goes into respiratory or cardiac arrest. There has been twice in the past 2 weeks when we've had 3 codes within a 20-minute time frame. What that means is that someone has gone into a rapid response respiratory or cardiac arrest. It needs immediate response from the rapid response team. So when you have 3 codes within 20 minutes and you have 1 rapid response team, there are unfortunately some very difficult decisions that have to be made with regard to triage and how we're prioritizing which of these patients is the most critical patient. How can we be 3 places all at once? With COVID patients, we're seeing that crash happen pretty rapidly. The progression is that the patients will come in needing oxygen through a simple nasal cannula. And once they have maxed out the settings there, we step them up to a high flow oxygen, and from there a BiPAP. And once they've maxed out those settings on the BiPAP machine, they are in need of intubation. And so that often happens. The crash is the point at which we can no longer sustain them on our highest level of non-invasive oxygen intervention, and they have to be intubated, which is the literature supports, and which we know in the data that's been put out. It's very hard to recover from ventilated status.
I see. So what are we finding dealing with COVID, the COVID crisis? What are we finding is helpful? Is it the prednisone? I've heard they started using prednisone, and it's really helped get people out of crisis faster. What have you guys found is working to help?
Yeah, so the regimen is prednisone or dexamethasone. Some patients with whom it's not counter-indicated may have remdesivir. Sometimes also coupled with a diuretic, which is a medication that pulls excess fluid off of the body because these patients are presenting with pneumonia, fluid in the lungs. And so, the challenge is that every body is different, and every body will respond to the treatment, as their body will. And it's been really frustrating on our end because we are doing everything we can, with the treatments that are accessible to us. And it's very discouraging to, having implemented all of those treatments, really kind of be tapped out in terms of what more we can do for patients. So it's really much to do about their respiratory status and trying to get ahead of that, trying to identify if they have something that's viral going on or bacterial, which could be treated with antibiotics, or what the cascading effect of the coronavirus is.
I see. This is Grassroot Ohio, and I'm Carolyn Harding, and today I'm talking with 3 medical professionals dealing with the COVID-19 crisis. We have ER tech, we have a travel nurse, and we have MD, Brad Cotton. I have a question for all 3 of you. What part of your work is the most gratifying? And conversely, what is the most difficult? Let's start with you, ER tech.
I think the happiest, the most gratifying is just, helping people. And I would say that the most difficult, and I know it sounds selfish, but it's just never knowing who the next, where it is, in my environment, where the virus is, who's got it. And I have vulnerable family members that I really don't want to give it to. So that's the most frightening for me, but it's also frightening to be helpless because I have no way of changing and the situation. And I see sometimes our units are full and we have to send people hours away from their family to a hospital that no one knows anything about. And that's terrifying. And so when I see that our COVID units are full and we have to send people out, and the lack of control over anything is really, really frightening.
Yeah, it's the novel virus. Everything is unknown. We know some. The general public knows very little, but you as medical folks know some. How about you, Dr. Cotton? What's been the most gratifying in your perspective from where you're at in this fight, and what has been the most difficult for you?
I guess starting off with what is most difficult, and as I said, is the fact that I've left my compatriots, my brothers and sisters on the field still battling this. I understand it was necessary that I report to the rear, so to speak, with health issues, still have responsibilities, raising grandchildren. I didn't have a right to risk taking their father essentially away from them. So that is the most difficult for it, is knowing that my people that I've worked alongside for 40 years, when you work in the ER, it's a special place. We see things, we see aspects of life in the world that other people don't see. I remember having a patient one time, for example. He had been a Columbus police officer and was now an Episcopal priest, which is certainly a transition, you understand. So we see working alongside each other in the ER, we see life unfiltered and upfront. And I miss still being in that environment and being in a feeling that we're doing essential, important work every day. But it was important that I do so. That's the most difficult about it. In fact, if I can get vaccines, I want to be back in there helping out. The most gratifying is, I guess, like I said, I'm not directly dealing face to face with truly sick coronavirus patients. So.
But what have you been able to do in your position to impact?
We're able to send people so they can get testing and at least find out if they have the illness or so forth. Although there's a lot of technical aspects of testing that need to be understood. And that is, one can come down with or be exposed to coronavirus on a Monday, so to speak. Or in fact, I'll put this example, as we're coming up on the Christmas travel season. One can be exposed to and develop coronavirus and maybe not even develop symptoms, but you on say the 20th or 21st, and you may not develop symptoms at all. You may not even be aware that you're sick. A lot of people will come get tested, not realizing that it may take anywhere from 4, 5, 6, 7 days after you contract coronavirus before the test even becomes positive. So it's important for the public to understand that going and getting tested somewhere, say on the 20th and 21st, does not clear you to visit family on the 25th and spread the virus. It takes a while for this test to turn positive.
You saying 4 or 5 days?
Yeah, the literature supports the idea it can take anywhere from 4 to 5 days from the time of your exposure. That's from the time the virus started replicating and growing within your respiratory tract before the testing even becomes positive. So again, it's not a good technique, and I urge everybody out there, as does Dr. Fauci, don't rely on testing to say that you're safe, that you can go visit people at Christmas. As I said, you could have come down with the virus on the 20th before Christmas, not even have any symptoms. The test might not even turn positive till 5, 6 days later. And meanwhile, you're spreading coronavirus all that time, and you will test negative. There is a delay in developing of a test positive situation.
That's huge, Dr. Cotton, because I have a 23-year-old son in California, and he gets tested, and I've been tested too. And I have visited my 92-year-old parents, and I wore a face mask the whole time, but I had no idea that it took that long. It could be incubating that long. And I guess that's a good advice for everyone listening. Don't think that you take a test that you're fine unless you've taken some time between. Let's go on to travel nurse. I'd like to know what has been the most gratifying for you in your work, and what has been the most difficult for you?
I'll start with the most difficult. And I would echo some of Dr. Cotton's sentiments about, being on the front line. As you mentioned, Carolyn, at the beginning of the show, I signed on in January of 2020 for an 8-week contract. And I extended and I extended and I extended, and I picked up another contract and I extended and I extended. And there was a part of me that felt a duty, and there was a part of me that felt guilty about not stepping in to help where I could. That said, there's the whole analogy of put your own mask on first, right? There was a short period over the summer where I stepped back to sort of, for reprieve and to reground, because I was not conditioned for a long haul. I typically do just a couple of contracts a year. And so coming back in now and just seeing the dire need and just seeing the surge and really the state of disaster that is evident at the hospital level, there's a part of you as someone who's taken an oath, to your vocation to serve and do the best you can to be a comrade. But what I would like to share, Dr. Cotton, is that your role is so important. Because what I know is that by the time patients come to my unit, it is a steep uphill battle. It is in the urgent care, it is in the community facilities, it is, those more first line of defenses, early recognition and early diagnosis that is important. And of course, prevention is, the best thing that we can all do. But the point at which someone has been exposed, has been diagnosed, getting them early treatment is the best case scenario for them. So I appreciate that you are serving within your capacity. and contributing to our overall efforts. On the hospital unit floor in the ICU, the challenges are the shifts are very long. Most of my shifts are, between 13 and 14 hours in full PPE with the respirator, which weighs about 10 pounds, and a power pack that is worn on a belt on the hips. And it doesn't seem like a lot, but when you're in that for 14 hours and you're trying to chart in your computer and you have that extra weight on your neck and you're in a hot, full suit gown. And as ER tech mentioned earlier, being hyper aware, of contagions all around and just having to be extra diligent and mindful about what you touch, the order in which you touch things, how you're sanitizing things, what a patient's contagious status is, how to move about safely in their space and how to keep them safe in their space. Another challenge has been that we have also become the surrogate family for these patients. On the IC unit, you're not allowed visitors, the exception being end of life situations. And it's a really difficult thing to have to suit up a family in PPE to say their last pieces, to their family members. So those things are challenging. One of the things that has been principal to me on every shift that I would leave on my travel assignments, I would ask myself, did I do everything I could today? And one of the challenges has been leaving the hospital, knowing that I did everything that I could and that everything just isn't enough. That there's just, we do not have the personnel resources. We do not have the capacity to sustain the volume of patients that are coming in. So that is challenging. What is rewarding to me,
Traveling nurse, we have 1 minute. Sorry,
Sure.
short. Give us what you are grateful for, and then
Yeah.
I have one more question.
What is rewarding to me is, the gratitude that families have that we are there and that we are doing the best that we can for their family members. And what is most ultimately gratifying is being able to, step those patients down and seeing them heal and seeing them get better and seeing them, go home from the COVID unit. And so that's what we're all here for.
All right, one more last question. If you were to give advice to our listeners, what is your advice? And keep it short. Let's go with you, ER Tech, first.
I know it's hard, but just stay home. You can have another Christmas. Once we're all vaccinated, we can have extra Christmas. We can have extra Thanksgiving. Someone I know, her little girls thought that they killed their grandmother because they'd been around her and they all had and they got the virus and then she died. And that's excruciating for little girls to have to think. And so don't get in that situation.
Thank you. How about you, Dr. Cotton?
I would echo ER Tech in that I've been working in emergency departments or on the street as a medic for 40 years. I've missed many a holiday or worked the night shift before it and just might as well miss the holiday trying to stay awake and be there. We all have missed a lot of holidays, and as healthcare workers, we ask that the public support us by listening to the science, paying attention to what the experts say, wear a mask, social distance, do not visit at Christmas, and help us as healthcare workers on the front lines. And listening to travel nurse, I'm grateful to her for the work that she does. Support her, support ER Tech, support all of us, and pay attention to the scientists. Wear masks, do not visit, social distance, and please help control this virus.
Thank you. And you, travel nurse, real quick.
Sure, I would echo ER Tech and Dr. Brad's comments, and just staying safe, doing the best you can to keep yourself and others safe. And I know that it's been challenging. We're social creatures. We miss being, engaging in that social capacity, but we really have to get through this. I would also caution with respect to the vaccine that's coming around, we still need to be diligent in maintaining those recommendations.
All right, that's it for our show. I want to thank you all three.
Thank you.
Thank
Thank you.
you.
In addition to our Friday 5 p.m. broadcast on WGRN.org, Grassroots Ohio will now air on Sundays at 2 p.m. at WCRSFM.org and also at 4 p.m. at WEJP-LP in Wheeling, Moundsville, West Virginia. You can also find us on SoundCloud, Apple Podcasts, Spotify, YouTube, Facebook, and Instagram. Thank you for joining us.